Right, welcome everybody to today's webinar on hepatitis C in community pharmacies. Thank you all for joining. Thank you those that acknowledged the 2-minute silence. I'm going to have a brief introduction. I'm Stuart Smith from the Hepatitis C Trust, and then I'm going to introduce the 4 fantastic speakers that we've got for you today. So firstly, and obviously, community pharmacies are a very integral part of the NHS. They're a key player in the prevention of ill health, and as such, they're well placed to play a really vital role in our elimination goals. In particular, reaching those people who may not be in touch with other services. Before this morning's webinar, I digged up some little facts about community pharmacy. There are about 11,000 of them across England. And the most interesting fact I found this morning was that the sort of demographic and placement of community pharmacy against other healthcare settings is actually inverse to populations who are affected or deprived populations. So actually 89% of the population can reach a community pharmacy within a 20-minute walk. However, in the most deprived areas, 99% of people can reach a community pharmacy within a 20-minute walk. So we know they're well placed. We're going to find out today the roles they can play in our elimination goals. We're going to start with an introduction from Mark Gillyon-Powell from NHS England, and who's going to tell us about expanding hepatitis C testing in needle exchange pharmacies. And then we'll have 3 expert speakers. Before we start, I'd like to say that the Hepatitis C Trust is a big fan of testing within pharmacy settings. We've ran pilots over the last decade, and one crucial one that's happened a few years ago was that was done with the London Joint Working Group. And I think that was delivered in 2017, 2018, and it allowed us to get some really key findings. Some of those that we found, I think, there were 308 people who used the needle exchange and were offered testing. 57% of them took up the offer of a test, and 38% of those were hepatitis C positive. So they were very good findings. But further to that, questions were asked, and 30% of the people we found in pharmacies didn't know that interferon-free treatment was available. And about 80% of those said that they would prefer to receive their treatment in pharmacy. And I think we're going to probably touch upon that also today. Before we go on with Mark, I would like to just say that you are welcome to type questions into the chat box. We'll probably go through all the speakers, and then at the end we'll have a Q&A session, and I think I'll be responsible for digging out some of the questions, and hopefully all of you will get an opportunity to ask your questions. So without further ado, I would like to introduce Mark, who's going to talk about the NHS England plan to increase testing within community pharmacies. Mark, over to you.
Many thanks, Stuart. Yeah, and thank you for asking me to come along today. I think you'd probably be hard pressed to find a venue at the moment where we're not trying to expand testing and access to treatment. From prisons and probation right through to sexual health services, emergency departments, and so on. But community pharmacies in many ways feels particularly important, partly because, as Stuart mentioned, they're sometimes the only service that our target population, our target cohort might access, but also because, as we found out during the pandemic, the community pharmacies were often the only or primary service that was open and seeing people when no one else was. So it's absolutely kind of crucial for us to make sure that those most accessible of services have the right kind of offers that we need for Hep C. If we could just move on to the next slide, please. This is fairly brief. Really, I wanted to, rather than go through all of the other work that we do, was just talk about where we're up to at the moment in terms of developing the NHS England offer in relation to community pharmacies. And it kind of naturally splits into the things we're doing nationally as part of the national elimination team at NHS England, and the things that we're trying to facilitate at a kind of more local level, mostly an operational delivery network level. So on the national perspective, we have now, since just pre-pandemic, introduced the Hep C antibody testing service. This took a significant amount of time to develop between NHS England, both Hep C elimination and primarily our pharmacy team at NHS England, and PSNC. And it's being offered as an enhanced service. We've had several hundred pharmacies register with that service. Not great take up in terms of numbers of people being tested, and that's partly because of some of the restrictions that went in the specification, and I fully acknowledge that it's not ideal. So, for instance, we can only test people through that enhanced service who cannot receive testing anywhere else. So anybody who's engaged with a drug service, we can't test there. Anybody who's got other engagement in other services. So it was really designed to be the kind of catch-all for those people who don't have anywhere else to go. I think that has seriously restricted its utility, and I think it's resulted in some frustration with some pharmacies, for which I'm sorry that that's happened, because people have to go through a huge amount of criteria before they can actually realize that somebody is or is not eligible for the service. Having said that, I'm in fairly regular discussions about whether or not we can expand the criteria in relation to the offer of testing, especially at the moment where, because of pandemic restrictions and social distancing and use of buildings, safe use of health buildings and so on, even if people are technically engaged with a drug treatment service, for example, it might be that their drug treatment service is limited for the numbers of people who can come in. So testing really isn't as widely available as it should be, or as it was pre-pandemic. So if that's the case, and people can't access, even though they have another service to go to, then they should be able to access, as far as I'm concerned, through the antibody testing service. So we're looking at whether or not we can expand any of those criteria. We've already looked at it as well in relation to people being released from prison, who might have a wait before they get seen at their local drug service, if they ever get there. So we want to try and make sure that we're picking up all of those individuals. We've been discussing for some time now about an opportunity for community pharmacies to dispense direct-acting antivirals, and potentially to prescribe direct-acting antivirals. So we're still in discussion phases about that at the moment, and looking at whether we can pilot potentially in London for a kind of expanded set of opportunities for pharmacies to support the work that the ODNs are already doing, but actually put some of it out in the community and make it more accessible, and make it so that people can get their treatment in the services that they're already familiar with, without being handed off to further services. So we do want to try and make sure that that kind of treatment is democratized more at a kind of local level in the services that are familiar to people. The other piece of work that we're doing is trying to look at how we expand provision of testing and access to treatment through needle and syringe programs. So both community pharmacy based, but also agency based. How can we make those pathways more acceptable to people and more easily facilitated? So we're looking at a number of ways that we could facilitate that for people. A lot of the national stuff, to be fair, is complicated, and the procurement issues are complicated, and it takes us a lot longer. So one of the other things that we're doing is looking at how we can do things at a local level through the ODNs and with other partners to be able to kind of short circuit or shortcut around some of those national restrictions that we have. So for example, trying to expand the criteria and methodology for testing, so that we can do not only antibody testing but PCR testing, which the national offer didn't do. How we can use community vans to expand the offer and have them visiting parked outside, whatever, in community pharmacy, so that there's an additional way that we can get testing out to those to all of those venues. And we're doing that at the moment through, we've asked all of the ODNs to give us business cases to look at how they can expand the testing offer through community pharmacies and agency-based needle exchanges. So we're working on that at the moment. I think the closing date for business cases is tomorrow, so we're hoping for some of those from our ODN colleagues. We know that there are some of the ODNs who are utilising things like their per treated patient payment scheme and other bits of national funding to co-locate peers or nursing staff or get them out there into services to carry out extended testing, and how we can then manage local treatment and referral pathways differently. That links back a little bit to the additional funding, additional testing, but it's trying to make sure that we can make that treatment and referral pathway work better at a kind of local level. So not everything is completely reliant on the national processes. And next slide, I think that's all I had to cover. Yeah, we don't need to cover that. People will have seen that. But yeah, so really, if anybody wants to contact me directly about any of the community pharmacy work that we're doing, or anything you think we should be doing, then feel free either to contact me on my own email or via the Hep C inquiries email address, and we'll try and build into the community pharmacy elimination initiatives work that we're doing. And I think that's everything from me.
Thanks very much, Mark, for that. And I think I like the way you broke down the national and the local. And at the Trust, we've welcomed the NHS England's approach and how much resource and how much you put behind it, but a big understanding that at a national level, there are extra complexities. We're going to hear about some more local initiatives now, and I think the two marry up very well. So thank you, Mark. Just to remind people, please do use the chat if you've got questions for Mark or any of the other speakers that we've got today, and we will get to them after we've heard from our three speakers. So next we've got Dr Ahmed Elsharkawy. He's consultant transplant hepatologist at Birmingham, and I'm a big fan of his work, and he's going to talk to us about testing in community pharmacies in Birmingham. So over to you, Ahmed.
Thanks very much, Stuart. Thank you very much to HCV Action and the Trust for inviting me to speak. I'm going to tell you about a pilot that we actually ran back in 2018 to 19, in Birmingham that was funded by MSD. But I'll talk you through the timelines and the database. So next slide, please. This is the outline of my talk. Sorry, Ada, next slide, please. So I'm going to give you a bit of a background and timelines, and I'll talk to you about the methodology of how we set the scheme up. I'll tell you about our testing figures. I'll tell you about our referral and treatment data as far as we can tell. I'll tell you about refusal for testing and reasons why people refused. Some of the lessons that we learned that hopefully will be helpful to those of you who are looking to set up local initiatives, and obviously end with acknowledgements. So next slide, please. So apologies that I finished the presentation late last night, but hopefully I've got most of the information captured. So actually this work came as a result of a bridging tender that NHS England awarded to the 3 big pharma companies involved in Hep C, and that ran between April 2018 and 2019 before the current elimination initiatives that we all know about were implemented in April 2019. So we were approached by MSD in January 2018 to gauge our interest. I think they'd put in preliminary proposal to NHS England at that point to do this in collaboration with Cefiad, but it was essentially MSD coming to us to say, we've got a fully funded pilot in community pharmacies using Cefiad point of care RNA testing for people who inject drugs, and would we be interested in taking part? And of course we were at the time. I'm very interested because we were looking to expand our outreach work in Birmingham. For those of you who don't know, the Cefiad technology allows you to take fingerprick blood, to put it into a cartridge, to put it into a machine, and it runs the actual PCR for hepatitis C and gives you a result within an hour. And it's actually a quantitative result, so it gives you a number rather than just saying a PCR is positive or negative. So next slide, please. So it's important to say that we weren't the only group approached. There were 3 other sites in England involved in this bridging tender funded by MSD. One was in London through the London Joint Working Group, built on some of the work that Stuart's already mentioned. And this was part funding, so it wasn't fully an MSD funded project, but MSD fully funded the project in Manchester, which they set up at the same time as us in Birmingham. And then Leicester came on board towards the end of that year period. And I've not got the data for Manchester, Leicester or London. And in fact, all our data is currently sat with Suman Verma, who hopefully is going to write it up soon. It was left to the individual ODNs in negotiation with MSD and Cefiad to decide the exact service design. And in fact, we did have some differences which will be interesting to compare in terms of the results of treatment and referrals. So for example, we used both incentives and peers as well as the system we set up. I know for a fact that in London, it was mainly peers with no incentives offered. And in Manchester, it was incentives without any peer support. In Leicester, I'm not clear as the exact mechanism, but it will be interesting, hopefully, when the paper comes out to have compared those 3 different approaches. Next slide, please. So I think the thing to stress, this was a very collaborative approach, and actually it ran really smoothly from the beginning. And I can't take any credit for that. It's just the way that the team got together. So we started immediately in January 2018. We had meetings with us in Birmingham as the ODN hub, with the Hepatitis C Trust, and with Danny Morris, who I know is on the line, with our local pharmacy committee, represented by Kevin Radcliffe, who actually is a non-medical prescriber who works for CGL, but is also quite senior in the Birmingham LPC, with MSD and with Cefiad. And what we initially did through Pharm Outcomes was look at local prescribing data on OST, and we were able to pick up the pharmacies in Birmingham that had significant numbers of clients. And then we sat down and chose a selection of independents and chains, because my gut feeling was that the independents would get up and running and test more than the chains, but we thought we'd test that hypothesis through the selection that we actually made. Next slide, please. So just as an example, this is a Google Map central Birmingham, and you can see the sites that we selected, just to say that there was quite a wide spread, and you can hopefully see from some of the names that there are some independents, and there's some Lloyd's pharmacies. Boots, for example, was represented, but we did have some independent pharmacies, and I'll come back to the differences in a minute when I talk about the testing figures, but also some in a bit in terms of the lessons that we learned. Next slide, please. So how did we set up the pathway? Well, I think the beauty and why this really worked was MSD did all the legwork in terms of contracting and negotiating. And I think that made a big difference, because we just don't have the bandwidth as busy NHS clinicians to be able to do that. It was agreed that the pharmacists would get a per patient incentive for testing, and it was at about £35, I'm pretty sure was what we agreed. And we also included incentives in terms of £5 for testing, £5 for coming back for the result, and a £10 incentive for attending for first appointment. And these were all in the form of vouchers. The appointments at the time were offered at our clinic that we ran at Scala House, which was the main CGL hub in the centre of Birmingham. It's since been abandoned. Or the hospital, but actually later in the scheme, we started using our mobile van that we parked at St. Philip's Cathedral in central Birmingham once a week. And we also actually found that when we had a cluster of patients, we actually went out to the local pharmacy. I say we, the royal we, it was Lisa Ellis, one of our main hepatitis C clinical nurse specialists, who went out and ran a focus clinic for those clients that were identified as positive within each pharmacy. Consent was sought from people at the time for the hepatitis C trust support. It appears to be able to support individuals. And it was important to say that Mark's mentioned, Sarah's specs, we were actually very liberal. So anyone who was thought to be at risk could be offered the test. So we didn't specify anyone in particular as an initial sort of, if you like, risk factor or initial burden. So they could be in contact with CGL, they could be known to drug services. We just said, if you're at risk of hepatitis C and you want a PCR, then we can do a PCR. And that's how we ran the scheme. Next slide, please. I think this was really important. So in terms of education, we had to, run some education events for the training of the pharmacists. So we did some evening events where there was pre-COVID days, there was some food run in a couple of the local Indian restaurants. And importantly, we compensated the pharmacists for their time to attend these evening events. And again, that was handled by MSD in negotiation with the pharmacies directly. We had presentations given by us as the ODN, MSD, and Kefiad in terms of the technical aspects of running the machine. And there was a Kefiad machine at the evening event with dummy cartridges available for demonstration, so that actually the pharmacists could see the footprint of the device and the laptop associated with the device that they would need to find space for in their individual premises. And once the scheme was live, Kefiad provided on-site training for anyone who wasn't attending the evening events. They supplied the machines, the laptops, consumables, and organized waste disposal. And this was all remunerated. This was all covered. The costs were covered separate to the individual per payment costs. And I think that meant that the uptake was pretty good, as I hope you can see in a minute. Next slide, please. So these are the next 3 slides are just some of the slides we presented as part of the educational event to try and just give you a flavor of what we were trying to get across to the pharmacists during these educational evenings. So we discussed with them, for example, how to refer into the liver services. We provided contact details. We really emphasized the fact that treatment has changed significantly from the bad old interferon days to sort of all oral therapy. We tried to sort of emphasize that, it's important to talk about sharing equipment. It's important about talking about people that they injected with. And again, we offered, hepatitis C peer support, without which I don't think this would have been anywhere near as successful as I think it was. And hopefully you'll agree when you see the data. Next slide, please. And we also talked them through some of the sort of the practical stuff that they might come up with, that it was important to say that, okay, for example, taking the second statement, if someone said to them, I've got Hep C, but I was treated years ago, explaining that if they've still exposed themselves to risk, they could get it again, that they don't get a natural immunity against the virus. So these were some of sort of the more practical things that we came up during and discussed with the pharmacists during the educational evening, which I think added value to the offer that we were able to give. Next slide, please. And we ended with some obvious key messages, that it's an oral tablet regime, that there's no injections, that we would treat everyone, that treatment wasn't restricted like it was in the old days to people who were stable and socially stable, etc. That actually we were not having to ask people to come to hospital, that we had outreach clinics that they could come to. And I think these were important key messages for the pharmacists to be having in terms of discussion before people were even tested. So I think it's important to sort of think about the messages that you want to get across. If you were the client, you would want to be hearing, and to make sure that your pharmacists were brought into that before they even started the testing process. Next slide, please. So we had to establish pathways for the pharmacists, and I'm not proposing to go through this with any detail, but essentially this was the scheme that the pharmacy had to follow. You know, and it was actually quite basic. It was, you know, offer people a test. If they accept, great, take them to a private consulting room and goes through things and perform the test. And then depending on whether the person waits to have the test or not, then they could actually get the result or come back for the result. If they decline, then it was actually provide some standard harm reduction advice and say you can come back and have a test on a future date. And we also wanted people to record the test. And I'll come back to the recording of how we did that in a minute. Next slide, please. So here is some data, and the bottom of the slide's cut off on my screen because of the Zoom bar, but hopefully you can see that. So as I say, initial approach was January. The tender started April, and we actually got testing up and running in July. And actually, to me, that was an amazing pace of things being done. The education events we ran in June, and we were up and running in July. And you can see a couple of things from this slide. I'm not proposing to go through it in detail, but actually our independents hit the ground running. So take, for example, Jutes, Fox and Goose, you saw that they got big numbers tested very quickly. And you can see that the seropositivity rate was running over, the viremic seropositivity rate, ignoring that, we only saw viruses. So we don't know how many of these people were actually antibody positive, but we were getting, of the tests that we were doing, we were still seeing 30% of people about 30% viremic. And so the independents got up and running, but quickly actually exhausted their numbers. So take, again, not to pick on them, but Jutes, Fox and Goose, you can see by month 4, their numbers are really starting to dwindle. And actually the project team recognized that earlier. And what we decided to do was, where we were seeing that the number of tests were coming down, and where actually the pharmacists were telling us, well, we've tested most of our clients that we know of, MSD and Kefiad and ourselves then made the decision to move those machines to different independents, so that we got different pharmacies on board in the last 6 months compared to the first 6 months. And I think that meant the figures that we tested were consistent across the whole project. The other thing to point out is, unsurprisingly, as I suspected, some of the bigger chains, and we had some problems with Boots, and I'm not going to criticize them. That's just the way that the big contract negotiations with big companies are more fraught with barriers to go through. But the Boots numbers for testing weren't great. It took us a while to get them up and running, and then again we saw the fall off. So you test your the majority of people that you know, and then the numbers tend to fall off. So you've got to be dynamic in terms of where your machines are located, and that's where the Kefiad technology is quite portable. So it does help in terms of being able to move things and set up new pharmacies. Next slide, please. So once the clients were positive, they were referred to us, and I think the beauty of this is that all the data was collected in the pharma outcomes software that the pharmacists used for all their internal databases. So we were able to look at the data quite quickly. At the time, what we were doing is we were seeing the clients, we were DBSTing them for confirmation and for hepatitis B and HIV and genotyping, and we were fiber scanning them where we could. And then we were seeing them, giving them 4 weeks of treatment, and then seeing them again, giving them the last 8 weeks, and then hopefully following up with SVR. Next slide, please. And we can talk about that maybe in the Q&A, because I'm conscious of time. So here's our waterfall plot, and I make no bones about it. We had 123 referrals of viremic patients. Only 53 attended their first appointment, but actually this is where we started getting a bit better. So once they've seen our nurses, and 2 are in fact negative on repeat testing, and 1 required changing carbamazepine that he was never happy to have. So there were 50 people eligible for treatment, of which we actually started 49, and 44 completed treatment. Now, to me, those figures in this kind of population is pretty good. But the problem was we had quite a lot lost to follow up, that we don't know whether they achieved SVR. We've confirmed SVR in 15 of those 44 that completed treatment. And in fact, 2, and it just shows you the difficulty and actually the tragic lives some of these people live, that 2 died after completing treatment, but before we could establish SVR. And this is just the nature of the clientele. Next slide, please. Here are the test refusal reasons. And as I say, in the interest of time, I'm happy to come back to this in discussion. So next slide, please. I think it's perhaps more important to talk about, next slide, sorry, Aidan, to talk about some of the lessons we learned. I've gone through them, but I think the keys to success were early engagement of the LPC. I think the evening training events were really, really important. I think we couldn't have done it without the Hep C Trust peers. For me, incentives made a difference, but not just incentives for testing, but incentives for coming back for a result and incentives for attending clinic. And we intentionally split them, the incentives that way, to try and keep people engaged throughout the whole process. And I think the fact that all the testing data was collected in pharma outcomes, enabling interrogation of the data and assessment of key performance indicators, KPIs, independently and relatively easily. Next slide, please. I think MSD doing all the contract negotiations made a big difference. Kefiad provided great technical support. And again, moving the machines, as I've mentioned, was really, really important. And actually what we learned was actually a lot of these pharmacists have amazing knowledge of their clients, and they know who injects with who, and they know where to find some of these people. And so when we talk about moving forward, and I know we're going to discuss about in terms of dispensing and hopefully even prescribing in community pharmacies, there's a huge amount of knowledge out there in community pharmacies that can be tapped into that will improve compliance in my personal opinion. And I think having a mix of independent and change is important. But I think critical to this was the fact that we could tell people that they were viremic very, very quickly. And I think that's really important as well. So next slide, please. I'm coming up to my last 2. What I would do differently, I'd have even more peer support. Can't stress that enough. I'd arrange peer-supported testing events in the community pharmacies. So that and I'd adopt more flexible ways of assessing patients and prescribing. We were still quite rigid in our treatment pathways and referral pathways back then. We're a lot more flexible and lean now, I think. I think we still in England, personally, my personal opinion, I'll be interested to see what people say, aren't good enough in treating injecting networks yet. We're not incentivizing people to bring their mates before we give treatment. And I'd argue you could say to people, right, you can get tested, but actually we'll give you even more of an incentive to bring, if you can bring a mate in as well. And I think that's where we need to perhaps box cleverer. I think we need to target needle exchange pharmacies, and I know that's some work that Mark and people at NHS England are looking into. We're talking about intravenous drug using populations, but actually equally there's a big percentage of the population who don't engage in primary care, who come from areas of high ethnic backgrounds, and whether we can use similar technologies, similar approaches. And I would ask for concomitant DBSTs to be taken. If you're going to prick the patient to do a Kefiad, get some blood spots on a DBST card, save it if they send it off for Hep B and HIV. When we talk about Hep B elimination, moving forward, this might be an ideal opportunity to be involved. I'm not going to mix messages, but I think that's important. So I'd like to end my last slide. Next slide with acknowledgements. Again, this is where I've missed a couple of people out, so apologies. Late night from the ODN, from our hospital, Sally, Lisa, many you know, and Larry, who was our ODN pharmacist at the time. She's now back in her hometown of Cardiff, and obviously David Mootum as chair of our ODN. Danny Morris and Philip Bonet were fantastic in this. Kevin Ratcliffe, who I've mentioned, was our main LPC liaison person. Deborah Cook, who's on the call from Kefiad, Kuldip and Sharon, and also Hayley Ward, who's on the call from MSD, sorry, not Merck, and all the community pharmacists and technicians did the hard work, and obviously the patients for agreeing for us to test them and treat them. And with that, happy to take questions in the Q&A. And next slide, and my contact details are on the next slide for those of you who want to contact me and ask any specific questions. Thank you. Sorry, Stuart, I overran.
Thank you, Ahmed. Fantastic, and proof of how vital this intervention can be. As if I remember, you ran that intervention when actually community services were doing very little testing, very small amount of testing within drug services. So it was fantastic to see that program being rolled out. I really liked the work you did with pharmacists on sort of standard question or standard responses they might get when they offer a test. It's something that we've worked at the Trust with for a long time, because it just encourages clients to really think about whether they should get a test rather than just, no, I don't want one, and the pharmacist to say, okay, see you later, kind of thing. So I like the pre-work you put in, and I really liked the way that we could see the shelf life of the intervention and how you would then move it on to another pharmacy. But for me, it warrants the question of, you know, with the elimination and putting in sustained interventions, when do you go back and maybe do retesting? Because some of the clients visiting these locations are possibly the ones who might be getting reinfected, for example. And again, the network of users, we know that people come in and collect their equipment, for example, for many other people living back in a house wherever they've come from. So that sort of further discussion and things that you can enlarge upon, fantastic. So speaking of network of injecting drug users, I'm going to move to our next speaker, Dr. Ryan Buchanan, Professor of Hepatology from Southampton. I've been a big fan of his work with the network of injecting drug users. Some of you are probably familiar with that. He's going to talk about the impact of community pharmacy engagement. So over to you, Ryan.
Thanks, Stuart. Aidan, I was going to share my own slides, but my system preferences aren't letting me do it. Do you mind sharing the slides I sent over? Thank you. I'll ask you to flick on if that's okay, unless I can take control of it. Okay, yeah, thank you, Stuart. It's a pleasure to be here. This is obviously a subject I'm very passionate about and have been involved with for some time. I was asked to talk broadly really about the impact and the potential impact of community pharmacy engagement in the elimination of hepatitis C in people who inject drugs. Just building on what's just been mentioned about networks and network-based treatment for hepatitis C, that's something I'm extremely interested in. It's the subject of my PhD. I'm going to touch on it at the end, and I'd be really keen to answer any questions that anyone may have about that. So next slide, please, Aidan. So Stuart and I obviously have the same bedtime reading, because I'm just going to re-emphasize some of the points he made about the staggering accessibility of community pharmacies. Community pharmacists as professionals are some of the most accessible clinicians to the population in the United Kingdom. And in fact, 90% of our population visit a pharmacy at least once per year. And Stuart mentioned this, there's this positive pharmacy care law where community pharmacists and community pharmacies are most accessible to our most deprived populations, which is the complete opposite of general practice, where they are most accessible to some of our most affluent populations. And we all know that the clients and the patients that we manage with hepatitis C, we need a significant footprint in areas of high deprivation and within marginalized communities. Next slide, please, Aidan. Other way, if possible. Thank you. So before I go further, I thought I'd just touch on what we're actually aiming for. So the definition of the elimination of hepatitis C was set down by a working group within the WHO in 2016, and it was published to the sort of wider consumption of others. in 2017, and it relies on the identification of 90% of cases of hepatitis C, so people with the disease, the successful treatment of 80% of these cases, and an ongoing, very low, kind of rather vaguely defined rate of new infections, so incident infections. And I think community pharmacies are key here because they can hit all of these three parameters. They can, as we've heard, be involved in the identification of hepatitis C. They can be locations for treatment, and I think Helen's going to present an example of that in a minute, and I'll touch on an example from elsewhere. And through, as a hepatologist, I think I sometimes forget this, but pharmacies have a really key and established community role in harm reduction through education, effective needle exchange, and opiate substitution therapy. Next slide, please, Aidan. Okay, so testing. I'm just going to run through a couple of examples first. So there is evidence, as has been indicated by Ahmed in the published literature, that testing for hepatitis C in community pharmacies is effective. There are published peer-reviewed articles from England, Scotland, and more recently there's an example from New Zealand and a single example from the United States. Interestingly, there are no published examples from elsewhere in the world, and that may reflect our slightly unique kind of community pharmacy service structure, or just the fact that we're slightly ahead of the curve than most areas on the elimination of hepatitis C. And there's also evidence of cost effectiveness. And on the next slide, I'm going to share with you an example of work that we did on the Isle of Wight to evaluate the cost effectiveness of the intervention. So many of you are probably aware, and some of you perhaps aren't, that NICE in kind of assess whether something is kind of financially worth doing or not using this thing called an incremental cost effectiveness ratio that basically balances the cost of the new innovation or the service against the gain that it gives the population in health, measured as their quality of life. So if you're dead, you have a quality of life of 0, whereas if you're alive and fit and well, it approaches 1. And so we measured the incremental cost effectiveness ratio of the intervention that the testing intervention we implemented on the Isle of Wight. And this was, like Ahmed, a dry blood spot testing intervention in community pharmacies that was available to anyone with a risk factor for hepatitis C. And perhaps we can discuss this later, but I thought that was quite important because it massively destigmatized the testing process, both for the pharmacists and for the people attending the pharmacy. And the cost effectiveness of the overall intervention was well below the rather arbitrary threshold that's set by NICE, which is £20,000 per quality of life gained. It came out at 3,689. So what we did on the Isle of Wight, because of the improvement in quality of life that was gained from the people that we identified with Hep C and treated, it was very cost effective. But what was interesting was when we looked at what would have happened if we'd restricted the intervention to just people who inject drugs, it was actually less cost effective. Because although they were more likely to test positive, so you save money on wasted negative tests, they were less likely to engage with treatment. And so that offset the benefit from having a larger number of people that were testing positive. And this scatter plot down the bottom here, which I appreciate may look fairly complex, the blue dots are results from a model that modeled testing anyone. And the green dots are if we just restricted the testing to people who inject drugs. And as you can see, the blue dots were generally slightly more expensive if you look up the y-axis. But if you look at the x-axis, they were much to the right. So they led to a greater gain in quality of life. And that was for two reasons. One, it was because people who were not sort of defining themselves as people who inject drugs were more likely to get treated. But also within this model was the increased death rate that's associated with active injecting drug use. And obviously, if somebody's going to die of another cause, then your hepatitis C treatment has not dramatically improved their quality of life because they've sadly since died, as was demonstrated by Ahmed in the last publication. in the last presentation. Okay, next slide, please, Hayden. This slide, two further graphs from the same article that just highlight that the cost effectiveness of testing in community pharmacy was optimized at low background hepatitis C prevalence levels. So if you look at the right-hand graph, you can see that the lines flatten off once you get above 0.1. So that's a background prevalence of 10%. And that kind of emphasizes that testing quite a broad population for hepatitis C, for instance, all of those with risk factors as defined in the NICE guidelines of 2012, is worth doing. And if you look at the left-hand graph, which is A, this is interesting. So the cost effectiveness was pretty stable and optimized if you just engaged 20% of your people in successful treatment and cure. So the work that Ahmed just presented, although in the end, I think maybe a quarter of people were proven to have an SVR, on the basis of the work that we did on the Isle of Wight, that intervention would have been cost effective. Next slide, please. Okay, so there were a number of pilots, as I described, that kind of informed the NHS England advanced service, which came out 18 months or so ago, which Mark described in the first presentation. And we've been doing some work looking into the implementation of this service over the last 18 months, which I fully accept has been massively affected by the COVID pandemic. And just a couple of features of the NHS England service is it's restricted to England only. As far as I'm aware from the service specification, it's available to any community pharmacy that has a private room, but as has been mentioned, it's not testing is not available for people who inject drugs who are engaged with drug support services. The tests are antibody tests only, and at present within the service specification is a plan for paper referral through to operational delivery networks, rather than using the kind of automated software like Farm Outcomes, which we used on the island and the Birmingham team used as well. And there's a £36 remuneration for the pharmacist for just doing the test. That's different from the pilot that we did, where pharmacists were paid for each component of the test they did. So conducting the test, uploading the result and delivering the result were separate things that they got paid separately for. Next slide, please. The reason why I'm presenting that is because we've recently done some work that's looked at the kind of uptake of the NHS England service across England. And this is work done by Charlotte Cook, who can't be here today because she's on maternity leave. She did a survey of ODNs in England and had responses from 20 out of 23 ODNs. And really promising result was that 95% of the ODNs have a pharmacy within the ODN that has expressed an interest, which is fantastic. So there's obviously enthusiasm for this, but only 4 ODNs had organised or delivered training events, and only 3 ODNs had a pharmacy which had actually started testing as part of the NHS England scheme. Next slide, please. So that's led to us doing some work as part of an ICOPTIC collaboration. So Stuart's involved with this, Ahmed's involved with this, Helen's involved with this, and I think Danny's in the meeting as well, is also involved with this. And the objective there is to draw on the experiences that many of us have had with delivering and implementing hepatitis C testing in the community in order to optimize the NHS England service. Next slide, please. And next slide. This may come up in the presentation that's following mine, but this is just to emphasize that community pharmacies have an evidence base for the delivery of effective treatment. This was a cluster randomized trial that was done by John Dillon's group up in Scotland. The red bars are community pharmacy treated patients, and the blue bars are conventional care. And as you can see, approximately double the number of patients that were treated in a community pharmacy setting achieved an SVR 12 compared to those that were tested in community pharmacy, but then sent through to conventional secondary care services. Next slide, please. And this is not my area of expertise, but it's a really important part of elimination that is delivered by community pharmacies. The NICE guidelines strongly support the delivery of needle exchange and opiate substitution therapy in the community pharmacy setting. There's kind of systematic review level evidence that the implementation of such a service leads to increased clean equipment utilisation in the population surrounding the pharmacy. And it's a service that is popular with pharmacists. Next slide, please. Okay, and next slide. So I think needle exchange and opiate substitution therapy is here to stay. Pharmacy-based treatment may evolve with time if commissioning issues are addressed in England. And hepatitis C testing, the widespread implementation, I think needs optimizing, but I think it has a key role in achieving elimination and crucially maintaining elimination. My final slide, because I think I've just got a couple of minutes left, is just going to elaborate a little on that. So in Southampton, we have published a network-based modelling study on the impact of a bring your friends approach to treatment for hepatitis C. And we showed that it was significantly advantageous to use a network-based approach to engage people with treatment, even accounting for the fact that the people that were brought along were more likely to become reinfected. And that was actually, although it sounds obvious, that was actually quite a novel finding and went against some of the other published studies from Australia and the United States. We've recently used that same model to try and predict what is likely to happen after elimination is achieved. So this is modelling in a network of 600 people who inject drugs in Southampton. And if we stop doing everything when the elimination threshold is achieved in a network in Southampton, after 5 years, the prevalence of hepatitis C will have risen to 20 to 25%. So there is clearly a need to continue testing services and treatment services after elimination targets are achieved, which is 90% identified and 80% of those treated. So how much testing and treatment is required? And that's what this graph shows. So if you focus on where the thick blue line crosses the black line is the prevalence, which is the arbitrary definition of elimination in Southampton. Along the x-axis is the number of people who inject drugs tested out of 600 per month. And where the fat blue line and the black line intersect is the number of people in that network that need to be tested per month in order to sustain elimination. And so here it's between 40 and 50, which is almost a tenth of the total network. That assumes a 50% engagement with treatment and various other assumptions, but that is a significant level of activity. So it's my feeling that community pharmacies need to be tasked with maintaining a testing capacity well after elimination has been achieved. And then on to my final slide, please. And that's it. Thank you.
Thank you very much, Ryan. Fantastic. And it's great to see some of the detail behind the NHS England scheme that's been rolled out, the progress it's making, the sort of survey and question work that's been done that hopefully will lead to some further guidance of how pharmacy schemes can get off the ground and deliver this intervention. Really liked you alluding to the promising work of John Dillon up in Scotland, where he's delivering the treatment and how effective that can be through community pharmacy. And finally, I love your work in maintaining elimination. The final couple of slides, that's going to be crucial for us. Elimination is not a static moment in time. You've reminded me of that over and over, Ryan, and how we maintain and keep the prevalence low is going to be important. So thank you for those insights. Keep the questions coming, please. I'm trying to monitor the chat, and we are going to get to some quick Q&A. I'm going to move on to our final speaker, Helen Boothman. Helen has been, well, she is the lead hepatology pharmacist at St George's, but I know Helen's been key in discussions when we've been rolling out, or NHS England have been rolling out testing within pharmacies. And Helen is someone that I would always go to for advice about case finding in pharmacies. So Helen, I think you're talking about providing Hep C treatment in community pharmacies. So I'm going to hand it to you.
Thank you very much, Stuart. Hopefully you can all see my slides. So as Mark alluded to at the beginning, unfortunately there's no national solution yet for hepatitis C treatment in community pharmacies. So I'm going to talk to you a little bit today about a project that we ran in St George's. So we ran a project called COPIT, which is Community Pharmacy Integrated Test and Treat. The initial project started in 2018 and 19, and we've actually revisited that project again more recently. Before I talk to you about that, I have to give you a bit of background about how we provide our hepatitis C medicines from St George's. So when the sequin was introduced back in 2016, NHS England mandated that medicines were supplied at the lowest acquisition cost. This meant minimising unnecessary fees, taxes and charges, which meant supplying at a VAT-free route of dispensing. Now, I'm not sure how many of you are aware, but actually hospital pharmacies, when they supply medicines, they incur VAT. Now, home care and community pharmacies don't incur VAT for this. So we had to work out how we were going to supply our medicines to make sure we hit all the targets for the sequin. We worked collaboratively with one of our community pharmacies and actually set up a novel dispensing route. Now, I can't take credit for this, and I know it took a lot of work to set up. But initially, we had to work with all 3 pharma companies who supply the hepatitis C medicines to make sure that they were happy for medicines to be supplied directly out of our outsourced community pharmacy. Now, pharmacies also can't access NHS contract prices, which is an issue. As we all know, these medicines are extremely expensive, with list price for a course of some of the treatments costing around £40,000. We obviously didn't want the community pharmacies to have to pay this, but initially they would have to pay and wait for rebates. It was quite work intensive for both the ODN, so our St George's team, and the community pharmacy to write reports to make sure the appropriate governance was in place, to make sure we were following the NHS restrictions on who could have hepatitis C medicines. So as you can see, there's a massive financial risk for the community pharmacy because they have to wait after paying for the medicines for the rebates to come through from the pharma companies and payment to come through from hospital, which isn't always as quick as we would like. However, Pearl Chemists Limited decided they were happy to take on this challenge, and a service level agreement was drawn up with them. This mandated that once our prescription had been received in the pharmacy, the medicine should be delivered within 72 hours to either a nominated clinic location, that's either in the hospital or our drug and alcohol centre locations. It could be delivered directly to the patient's home or collected from another branch of Pearl Chemists Limited. All the medicines were supplied in a tamper-proof sealed bag. And actually, in addition to our project further on, we allowed returns. This mitigated the financial risk of chaotic patients who were not starting treatment. So as long as they'd been stored in an appropriately secure and temperature-controlled environment, we could return these medicines. So the fact that we could deliver medicines into different community pharmacies for collection made us think, especially around the time when everybody else was bringing up these projects for testing, we'd like to have a pathway where you could be tested, treated, assessed and treated in the same location, making it more convenient for the patients. We know the attrition rates for this are quite poor, so we thought this would be quite beneficial to our cohort. We submitted a project plan and were awarded a Gilead Fellowship back in 2018. So the aims of our project, to identify patients with risk factors for hepatitis C. And as I think Ryan and Ahmed have alluded to, we didn't want to make this just injecting drug users. We wanted to make sure that anybody who had any risk factors could be tested if they wanted to. We have a high population of Eastern Europeans and South Asians in South West London, so we wanted it to be open to them as well. We wanted anybody with risk factors identified to be encouraged to have a blood-borne virus test within the community pharmacy, and often you're not offered a blood-borne virus test anywhere else, so this was actually the only chance they could get. Like I said, we wanted to offer continuity of treatment in one location. We also wanted to engage service users with positive results into treatment. So, as Ryan said, a lot of community pharmacists have great links with some of their clients, really good relationships, and actually some of the clients that we knew from drug and alcohol centres had refused to be tested or treated, and we wanted to use this project as a way to help engage with them. We initially set up in 5 community pharmacy locations, and 3 of these were Pearl Chemists Limited. Unfortunately, Pearl don't have any needle exchange pharmacies, and as we all know, the needle exchange clients are one of the biggest populations we want to target. We discussed with a number of our stakeholders, and we actually set up in 2 other community pharmacies. This would be the same process. Separate SLAs, so separate service level agreements, were drawn up with these community pharmacies and with Pearl Chemists Limited, so that it was a completely different setup to the dispensing. This included fees for testing, for assessment, so we used their consultation room for assessment, so we paid them room hire. We also included a supervision of treatment fee. This wasn't to do with collection of treatment, but separately a supervision of treatment. We were able to work with our local community pharmacies and advertise with all of our local needle exchanges. So our leaflet was included in the bag of every needles given out during this time. We also had posters around and tried to advertise as much as possible in drug and alcohol centres as well. Like the other projects, we provided training to community pharmacy staff, and before COVID we were able to provide face-to-face training again with food, and we had really good engagement. The engagement was not just from the pharmacies providing the training, the testing, but actually from other pharmacies who wanted to know a bit more and be able to signpost. During the training, we talked about hepatitis C, we talked about identifying risk factors, and we also talked about how to engage those with risk factors into a test. We also gave an overview of the treatment, how well tolerated it was and what to look out for. And then part of our training was about how to test. We wanted to make sure that all pharmacy staff, so from counter assistants to technicians and pharmacists, were confident and competent in providing the testing. So, unlike the 2 projects we talked about before, that used DBST or the Kefiad, we used capillary blood testing. Many of you may have heard of capillary blood testing before. We've talked about it a number of times. But they use a small amount of blood, so 250 microlitres. It tests for all the blood-borne viruses, so hepatitis C, hepatitis B, and HIV, which we thought was quite beneficial in this project. An advantage, although it's not as quick as the Kefiad, it does test for hepatitis C viral load, so we can check if a patient is active just with 1 test. And it also does a genotype straight away. These results are processed in 3 to 5 days. Now, all our pharmacies were in very convenient locations around the hospital, so either walking or cycling distance. We were able to either collect these for them or get them delivered to their local GPs for delivery to our South West London pathology lab. Now, the results of all these tests were sent to the community pharmacy via secure email. They were also sent to our viral hepatitis team so that we ensured that these patients were followed up in a timely manner. We actually found that no patient didn't return for their test, because a lot of these patients are actually visiting the pharmacy on a daily or weekly basis anyway. We did, however, incentivise with £5 Greggs vouchers for them to return for their results. We also use the capillary blood testing throughout this pilot for assessing response to treatment, sometimes at treatment week 2, sometimes at the end of treatment, and for an SBR12. So as I said, we get the patients engaged into testing by the community pharmacy team, or they can be self-referred in for a test. They complete very simple pre-test paperwork, including patient details, risk factors, and follow-up details, contact details, so we could get in touch with them. They also obtained consent, and part of this was to make sure they were happy with the result coming to St George's and for us to follow them up quite quickly. If they got a negative test, the result was fed back by the community pharmacist. And again, this included post-test counselling, lifestyle advice and harm reduction information. If we knew that the patient was continuing to put themselves at risk of Hep C, then they could be offered a retest in 3 to 6 months. If the test came back positive, then the community pharmacy could deliver this test result. However, they could also book an appointment in with the hospital team to try and engage these clients. As I say, we were very flexible as the community pharmacies were very close, so we were able to visit. And often we know with a lot of this cohort that they attend at a certain time of day, so we were able to attend for them. We would check the patient before to see if there was any assessment already done in either the hospital or the drug and alcohol centre. And if there wasn't, then one of our nurses would attend the pharmacy consultation room and do venous bloods to check liver assessment using FIB4. We didn't necessarily test or assess out all these patients in the community pharmacy. They were offered the option of community pharmacy, local drug and alcohol centre, or hospital treatments. As with normal, they would then go through the MDT, and an individual treatment plan was produced, and a prescription written and ordered in the usual manner via Pearl Chemist. So, along with the patient, it was the patient and the MDT's decision about where the patient should be treated. If they were decided to be treated in the community pharmacy, this is where it becomes a little bit complicated. So we use the community pharmacy as a collection point rather than a dispensing, as we knew the problems of setting up dispensing takes a lot of time and is very cost intensive. The medicines are all supplied in a tamper-sealed bag, as I said, and these bags would be handed out to the patient rather than the separate bottles, and the pharmacist took no responsibility for the dispensing of these. We also discussed the frequency of the collection. So for a number of our patients, they were on opioid substitution therapy, at which case they could be provided their treatment at the same time. Each patient signs a consent form for treatment, and this is regardless of where they're being treated. This is the reason this is for our GDPR, as we're providing their confidential information to a second party, Pearl Pharmacy, for dispensing. If they were receiving their medicines through the community pharmacy, we added an additional disclaimer telling the patient that the responsibility of dispensing the medicines sits with Pearl Chemist Limited, and the pharmacy they're collecting from is mainly a collection point. As I said, the prescription is signed and screened by the viral hepatitis team, so we have an overall view of who is being tested and treated in these community pharmacies. This is just an example of our prescription. Like I said, we can choose to have weekly, 2 weekly, daily, or twice weekly bottles, or 2 weekly bottles. We had a supervision sheet, and like I said, the supervision of the treatment was completely separate to the collection of the treatment. So we could pay a supervision fee for the pharmacist who was handing out the medicines. So here we go, just a bit of an overview about what I've just discussed. The picture in the corner is actually 2-week supply of a patient's medicines who was getting daily dispensed, so all separate bags, just with the name of the patient and the date of birth on the bag, so that the pharmacist can just check who the patient actually is. So the viral hepatitis team made sure we had regular links with the patient, and we also use our hepatitis C peers now. It was important to know that the community pharmacy were not responsible for the treatment, and any questions they would refer directly to us. We would also make sure we tried to have a monthly review if possible in the consultation room in the pharmacy to make sure they were getting on okay before we supplied the next lot of prescriptions. If medicines were uncollected, then this was informed to Pearl Chemist so that they could let us know that patients were not collecting their medicines. As I said, we use capillary blood testing for end of treatment and for SVR12, and we asked the pharmacy to do this to make sure that, again, continuity of treatments. They again continue to provide lifestyle advice and harm reduction counselling for these patients who've been treated. I just want to give you an overview of our outcomes now. We didn't quite reach the dizzying heights of testing success that Ahmed and some of the other testing groups have managed to achieve. We tested 50 patients in some of our pharmacies, and as I said, only 2 of them were needle exchange pharmacies. And unfortunately, with the size of our team, it's quite time intensive to make sure you are keeping the pharmacies engaged. As everybody knows, community pharmacies have a lot of other things to do, and we wanted to try and make sure we were keeping them as engaged as possible, but a lot of these testing came in smaller time frames. We did, however, find 10 patients who were antibody positive, and 8 of these had active infection. We did successfully assess 5 of them in the community pharmacy and actually have 100% assessment to cure rate, which we thought was quite impressive. It's important to note that not all of our patients required daily supply of medicines. So we did supply with their OST, but some patients, a couple of patients had weekly dispensing, and they came in often for their needles those weeks. 2 of our patients were previously known to our team and actually had already been offered appointments in the hospital and the drug and alcohol centre, but had not attended for any of their hepatitis C appointments. It actually took the relationship and the strong links with the community pharmacy team to get them into treatment, as they at one point did not think they were worthy for treatment. So it took a lot of persuasion with a lot of help from the community pharmacy team to get them into treatment, but they managed to achieve an SVR12. It's also important to note that 4 of our patients were on OST. So the new NHS England specification that only allows for patients who are not on OST and not on the drug and alcohol centre to be tested wouldn't have been picked up in our project. And also, as we discussed previously, having other risk factors in the project is really important. We identified one patient who was actually tested as his daughter. He just moved over from Pakistan, and his daughter had seen the leaflets and decided that she wanted to get her dad tested, and he actually was positive. Now, he had a complex medical history and had been reviewed a number of times at GP, but never been tested for hepatitis C, despite his risk factors. So had we not had the project running, he would probably not have identified this, and he has now been tested and treated. For the other 2 patients that we found RNA positive, one of them unfortunately has been lost to follow-up, but we continue to use the hepatitis C peers and the find and treat team to identify him and locate him. The other patient was actually tested positive, was treated in our local drug and alcohol centre and has achieved SVR12. So success all round. So the advantages of this project and testing and treating in community pharmacy. So as we know, we can identify patients with new hepatitis C or patients who are unaware of their hepatitis C. It's real patient-centred care, and it helps us provide treatment in one location to patients who maybe otherwise wouldn't have attended for this treatment. So it improves the engagement with them and improves the adherence. I think the communication links with the community pharmacy also help to increase awareness of hepatitis C, both within the healthcare professionals and within the high-risk patients. Because a lot of these patients continue to be seen in community pharmacy, the pharmacists and the pharmacy staff can reinforce the message of reinfection and retesting as they're ongoingly treated in the community pharmacy. And as Ryan said, it's really important to offer these retests, and community pharmacies are often a best place to do this. The disadvantages, however, this is not replicable on a national level, unfortunately. It is extremely time intensive and cost intensive. Labour intensive, with all of the SLAs that need to be set up between each pharmacy. It's also not sustainable, and especially in light of COP26, we see that 28 bottles of plastic bottles for one course of treatment is not appropriate. It's also not utilising all the skills of a pharmacist. So although we're utilising the skills in the testing and the discussion of harm reduction, you're not utilising their dispensing skills and their counselling and treatment and supervision skills in this project, unfortunately. So, as Mark said, there is the NHS England Advanced Service released last year. It's not quite hit the criteria that we'd all like, with only antibody testing and a limited cohort. We have revisited our project this year because we are working on the back of the NHS Advanced Service and actually helping those pharmacies who identify anybody who's positive to provide CBT testing to confirm active virus, and also looking at them providing treatment as well. As Ryan said, the ICOP6 study is looking for a consensus statement on the work of community pharmacy, and there is a massive drive, we know that, to provide hepatitis C treatment within community pharmacy, and NHS England are working really hard and engaging with LPN, LPC and the PSNC to try and work around these logistics to provide hepatitis C treatment through community pharmacies. So hopefully watch this space. And that is all I have for you. My email address there if you've got any questions, and I know we've got questions now.
Oh, sorry, I've unmuted myself. Thank you so much, Helen. Very insightful. Thanks for all the work that you did on that project. And very interesting to see the challenges. Hopefully, you know, some of those could be overcome. We hope that the work will continue to try and deliver treatment within the pharmacy settings. I thought that actually, you know, the numbers showed that actually once you're diagnosed and found RNA positives, you got most of them treated. And I love the patient-centered care. Ask the patient what suits them, and if it's the pharmacy that suits them, it's a fantastic way. And the other thing I was thinking when you were presenting was the pharmacist actually sees the entire outcome. You know, so it probably encourages them to test people when they can actually see the joys of someone curing their virus. And the patient who wasn't an injecting drug user, I think that's a question that I'm going to have. I'm going to move to the questions that participants have been posting in the chat. I'm going to go through them as they came in. Many of them have been answered. And I think all of you can see the chat. We've got 15 minutes left, so I'm going to go through them as I can read them. Some have been asked by Mark already, are answered by Mark. Which incentives did you use? That was answered by Haley. Thank you, Haley. And our experience of incentives is they can be anything that's an incentive. And again, they're sort of usually locally negotiated. I like the one from someone called Sam. So Sam's asked if pharmacies get new service users after the intervention's been moved, with Ahmed saying that they moved the machines on once they've done the existing footfall customer or clients within that pharmacy. Would they know where the machines were and how to signpost new patients? Ahmed, do you want to speak to that?
Oh, that's a really good question. Thanks for that question, Sam. So the answer is, honestly, I can't remember whether we signposted clients. I mean, I think actually word got out through the networks of people who injected drugs that testing was being offered in this pharmacy. I mean, interestingly, if this was to carry on, what you probably do is rotate your machines through those pharmacies where you knew most of the OST was being dispensed. And in terms of, I totally agree with the comments that have been made about elimination, about the need for retesting, and about elimination is one target, but actually to maintain elimination is another issue altogether. So I think that's a really fair point. But I think hopefully with all Mark's work, we've flooded the environment with opportunities to test Hep C for Hep C, so that there was always going to be somewhere where someone, if they wanted to have a test, would be having a test. But I'm still not sure we've got metrics for retesting fully up and running anywhere in the country, actually. And then just one final point, Stuart, if I may, Sally, our ODM manager, reminded me by email that in fact we treated another 20 patients after the project was finished. I haven't included in my numbers, so apologies about that. I was just going on a database of people that were referred as the project was live. But absolutely, I think it's important that we think about retesting and think about signposting people. But that's where the peers have a great role to play as well.
Thanks, Ahmed. And actually, while you're on, I'm going to put another question back to you. Helen identified a South Asian, I think it was South Asian patient, wasn't it? The father of someone who attended the pharmacy. What do we think, or what your views maybe, Ahmed, working in Birmingham, where there's high areas of the South Asian community? Is this an intervention that can just slot into pharmacies that are attended predominantly by people from South Asia?
So we actually ran an AbbVie, so we got some money from AbbVie to answer that exact question. And we did a DBST project in a couple of community pharmacies in areas of high ethnicity, mainly South Asians in Birmingham. And actually our pickup rates for Hep C were very low. What we did pick up was 3 or 4 new cases of Hep B. And so I think actually the answer is yes, I think there is an opportunity. If you think about your you know, your first generation immigrants who don't necessarily access their GP surgeries very well, but pick up their diabetic medication regularly from their community pharmacies. There's an opportunity to test there. I think we need to write up our data, which hopefully we will do. My colleague Emma Hathorn was the main person running it. So Hep C, we didn't get great uptake, but then we didn't test a huge number. We tested a couple of hundred people. So maybe we just didn't target the right audience. But I think there is definitely some mileage in that. And we'll know a bit more, because the other thing is we were doing a project with PHE looking at leftover blood sent in for cholesterol checks to Heartlands, which is an area with a high Pakistani population around there. And we'll hopefully get the results of that soon, just to see what the actual seroprevalence of viremia is in that population. So watch this space. That's something that we're running with Sam Jazz in PHE.
Thank you, Ahmed. Just a reminder, use the chat, please, if you want to ask any of our panelists specific questions. A question from me again. So Mark at the beginning mentioned that several hundred pharmacies had registered for the testing scheme. I wonder if I can go across to Ryan, who's been doing some work on, well, obviously you've done some background work on the efficacy of the program, but is there something in here about managing expectations of pharmacists who do register for schemes? Do we think that we need to have some guidance that tells pharmacies it might not be worth them entering the scheme if they've only got 4 patients that they see for OST, and considering what we've heard about how much work goes into delivering this program? And I wonder if anyone's got any thoughts on that, because, you know, a pharmacist could walk into this, lots of time for training them, lots of SLAs and contracts to be signed and negotiations to be made. Do we say to them, well, actually, you only see 4 OST clients, and we know that's the footfall you're only ever going to have. So maybe delivering a van or parking a van outside might be a better option for that pharmacy, for example. Do you have any views on that, Ryan?
So I think expectations should be managed, because it's, you know, pharmacies are businesses, and they need to invest in things that are going to give a return to them. I think that should probably be done at a kind of ODN level, at the point where initial conversations are had with interested pharmacists, and somebody within each ODN says, well, actually, you know, you're not kind of a potential hotspot for us. So that's one thing. The other thing is, well, if a future service opened up testing to people with a range of risk factors, then that problem partly goes away, because you know, for instance, if you were in an area with a high South Asian population, then even if a community pharmacy doesn't offer OST at all, it can serve a high risk population as is defined as requiring testing by NICE. So I think that's something to think about in the future. But yeah, in the short term, I think at an ODN level, we need to be pretty clear that the pharmacy coming in is going to get something meaningful out of it.
Thanks, Ryan. And I wonder if we get any feedback from pharmacists who have been involved with the various schemes, and whether they felt it was worth all the effort that they put in, for example. But Mark, you've got your hand up.
Yeah, it was just to add to that, really. One of the things we did when we were looking at the original service design for that piece of work was consider whether or not we should actually just offer it to, for example, needle exchange pharmacies. So we knew which pharmacies were already seeing some of our clients in terms of some of the target population, but because of national procurement regulations and regulations from PSNC, the rules were it had to be offered to every single pharmacy in the country. So whether or not they'd ever seen or tested or whatever individuals with Hep C, it had to be a kind of national offer available to every single pharmacy. So we weren't able to kind of refine it down and say these are the kind of key targets. So as was mentioned, we're having to rely to a degree on ODNs identifying who those busiest pharmacies are, and hopefully encourage them to join.
Okay, thanks, Mark. There's another question in the chat from Louise here, and it's another great question, actually. So Louise would like to know how the data may have been shared back from pharmacies to drug services so that both knew who had been tested and results. I'm going to open that question up to anyone who wants to tackle that.
So I'll answer that. So Louise, anyone in our scheme, anyone who is known to CGL, who's the Birmingham Drug and Alcohol Service Provider, said back to them that they'd been tested, especially if it was positive. We offered and CGL was happy for us to see them, even if they weren't known to CGL and weren't registered, to see them in our CGL-based clinic for them to then try and engage them in OST. So it was a two-way conversation. We did involve our local drug and alcohol service. At that point, a lot of the data sharing agreements that we have in place weren't quite mature enough to enable true information sharing. I think it would change now, because now actually we all share data, Hep C Trust, our local drug and alcohol services, and the ODN. So I think it'll be more robust now, but it's a very fair point. And when we set it up, I would encourage anyone who wants to set up a service to make sure that tripartite communication is flowing, especially when it comes to retesting.
Thank you, Ahmed. So the chat's run a bit dry, I think.
Stuart, can I just add to that? So that's been raised quite a bit down here in Wessex, and we're in the process of amending the consent process around the pharmacy test to include notification of the drug and alcohol service if you're tested. So that's being amended within a pilot that's running independently of the NHS scheme, which is using farm outcomes. So they're kind of it's easily adapted, and consent is recorded as a kind of tick box. The only other thing I just think about here is that if these individuals are continuing to put themselves at risk, repeat testing is a good thing. And I've always been a little anxious about people being anxious about, has this person been tested too recently to have another test? I mean, I'm not entirely sure there's such a thing as tested too recently in this population. And I just worry that we've just got to be really careful we don't put up barriers to retesting. And actually every professional they encounter should be asking, when were you last tested? Oh, it was vaguely recently. Well, why don't we do another one? Because it sounds like it might have been some months ago. I think is an important kind of mindset to have.
Thanks, Ryan. And actually that's come up at the Trust here, where we've had clinicians who are they're keen to get people back in for treatment if it's a second time or third time as soon as possible. They feel it's crucial if we're going to eliminate. So yeah, the time between the retest, I mean, retesting is going to be a big discussion as we move forward with our elimination goals, and how we maintain any kind of elimination. So thank you for Ryan. And I like what you said, because that's with the Trust has got round information sharing. Maybe I shouldn't say this, but I'm going to, but sometimes it's the patient's choice where their information is shared to. So just going to that consent form and saying, if I'm positive today, I'm happy for the drug service to be notified of my result. And as long as the patient understands that and consents to that, then it can sometimes negate the very painful information sharing agreement process that sometimes just isn't possible. So thank you for that. So a quick question for Helen. We've got about a minute left, but am I right in one of the ways that you got enabled to deliver treatment in pharmacy was calling it collecting and not dispensing? Could you just enlarge on that for a minute?
Yeah, so we were able to get the patient to collect the medicines as long as the pharmacist took no responsibility for the medicines that were being handed out. This is how we got around the secondary dispensing. Now, it's a definite like sticking point, I think. So it's not something that we would be rolling out on a large scale just because of the cost, the implications, and the work. And it's also just not the best way for a patient to receive medicines.
Okay, thank you. And we are at 12:31, so we're a minute over. So I'm going to close the session by thanking everyone for a fantastic discussion. It looks like we could have more discussion here. And I certainly hope that the intervention is going to progress, especially now that we're out of the real trauma of the pandemic, and you know, maybe winter will present another little problem, but maybe into spring we might see this intervention really gaining some ground. So thank you for everyone who's attended. Thank you for all the panelists. Please get in touch with HCV Action if you've got further questions and you want us to direct them to some of the experts we've heard from today. So thank you very much, and I shall close the session.
Thanks, Stuart. Thanks, Mark. Thanks, Ryan. Thanks, Helen. Thanks, everyone.
Thank you.
Thank you, everyone.